Hey Tanya, Joe Candido is my name. I'm one of your students and my student number is 11683707. Tanya, this is my video of a cardiac arrest. With imagination, this is my defib, my cushion, and this is my medical equipment. So here goes. Okay, I arrive at the scene, I go through my ethane report, which is exact location is 10 Smith Street, Smithfield. Type of incident is cardiac arrest. There are no hazards. Access and egress is via the front door. There's only one patient and backup is required as this is a cardiac arrest patient. My partner and I have our PPE, which is safety glasses and imaginary gloves. And as we are approaching the patient, I'm looking for a number of things. My general impression is a 60-year-old male, approximately 80 kilos in the supine position. My partner and I have 360-degree access, and I'm looking for indications to withhold resuscitation, and that is not indicated in this situation. So as we walked in, Bob does not appear alert, and I've called his name. Bob, can you hear me? Bob. He's not responding to my verbal stimuli. I'm feeling Bob's trapezius, and he's not responsive to painful stimuli. I'm now going to check his airway. I'm considering C-spine, any C-spine injury, but that is not indicated in this situation. So head tilt, jaw lift, hold his chin down. His airway appears clear. I'm now listening for breath sounds and the rise and fall of his chest, as well as feeling for a carotid pulse for 5 to 10 seconds. I am maintaining this position. I confirm with my partner that this patient is in cardiac arrest. If he had a shirt on, I instruct my partner to expose his chest and commence compressions at the rate of 100 to 120 compressions per minute at a third of the depth of the patient's chest, and allow the chest to fully recoil. My patient acknowledges that he will follow my instructions. So I now turn on my defib. If the patient was wet, I would dry him. If he had a hairy chest, I would shave the areas where the paddles would go. So as I mentioned, defib is on. I'm applying the paddles, one there, applying the paddles. Now I'm going through my coach process. So compressions continue, oxygen away, all others clear, charging. My hands clear, your hands clear, partner, we're all clear. Evaluating, confirming this rhythm is a VF, ventricular fibrillation, partner. My partner confirms. I'm looking at the patient and I shock the patient. Partner, this is cycle 1. Continue CPR at the rate of 30 to 2. So my partner is continuing compressions. I'm getting my OPA out. I'm checking the size, earlobe to the corner of the mouth. I've got to do this for Bob, otherwise I can't get the OPA in. Put it in backwards, and then I spin it around, and the OPA holds Bob's tongue down. Yeah. My BVM, I will attach the hose to the BVM, and I would also at the other end of the hose to the oxy bottle, and the flow rate would be 15 litres per minute. So Bob's counting, my partner is counting. He gets to 28, 29, 30. I've got a good EC grip. All right, so this is start of cycle 2. So I'm thinking of my reversible causes, hypoxia, which would be oxygen, hypovolemia, which would be bleeding control and fluid replacement. Hypothermia would be warming the patient, and hypokalemia, which would be with potassium, and hyper, which would be calcium, and hydrogen ions, which would be just airway management, which is what I'm doing. So this is the start of cycle 3. So now toxins. Toxins would be naloxone, cardiac tamponade would be at the hospital, and tension pneumothorax would be ICP. For chest needle decompression, and thrombosis, cardiac and pulmonary would be at the hospital. And once again, I would have called back up at the highest clinical level for this situation, which would be intensive care paramedics. So we would continue this for 2 minutes. On the 5th cycle, which, let's fast forward, my partner would continue compressions, he's counting out aloud, and then I'd go through my coach process again, which is compressions continue, oxygen away, all others clear, charging, my hand's clear, your hand's clear, evaluating, and whilst we're evaluating, I'm changing positions with my partner, so my partner's now at the head, I'm doing compressions. That is, the rhythm is VF. Can you confirm VF? Yes. Can you please shock the patient? Looking at him at the same time. He does that. I'm on compression. So I'm giving compressions. Let's fast forward. So then we get to the 5th cycle again. So we go through the whole coach process again. And whilst we're evaluating, then I move to the head. My partner's continuing compressions. Can you confirm that this is a VT? He confirms this is VT. So I feel for a pulse. I feel a pulse. I dump the charge. And now I just go through my ABCs again. So he's got a supraglottic, so he's got an OPA in there. We are breathing for him and he has no pulse. So I'm applying this ventilation, one ventilation every 5 to 6 seconds, which is about 10 to 12 per minute. Whilst I'm doing this, I'm instructing my partner to go and get a stretcher. He brings a stretcher over, so we can obviously put the patient on the stretcher. Also, I've got to consider my medications, and my medications, after the second shock, I would consider epinephrine, which is adrenaline. At 1 in 1,000, it would be 1 milligram in 1 milliliter. If it was 1 in 10,000, it would be 0.1 milligrams in 1 milliliter. And after first administering adrenaline, I would also consider amiodarone, which would be 300 milligrams. So after 6 minutes, I would replace the OPA with a supraglottic airway, so that way it gives me the ability to attach an ETC-02. I'll put the extension on first on the iGel, and then apply the ETC-02 monitor, and then just continue the ventilations. And this would give me a cardiac output on the patient. Normal range is 35 to 45 mmHg. If it's good CPR, it would give a reading of about 20 mmHg. 10 or less mmHg would be a poor outcome for this patient. So now we would place the patient onto the stretcher. Before doing that, I would just check the ABCs again, put him on the stretcher, and then put him in the ambulance. Once in the air, before putting him in the ambulance, I would again check the ABCs, get him in the ambulance, check the ABCs again, then expedite to the closest emergency department, which would be Parramatta Hospital in this case. En route, I would continually monitor his ABCs and monitor his vital signs with the BGL, with his just the normal vital signs. Thanks, Tanya. Bye.